All right, Harsh, have you got anything from the course you wanted to talk about?
Most of it pretty much clear.
I'm pretty good, you know.
Yeah, the technique we have to practice a lot, but yeah, the biomechanics and other
All the other stuff's okay.
Quite clear. Yeah, no.
Okay. You're on course.
Yeah.
You know, you're not behind other courses, you're right on course, so I'm not worried. Kim, have you got anything you want to talk about?
Yeah, I did want to ask you, because I watched your webinar from last week, and when you were talking about when the vertebrae kind of slips and then rotates.
Yeah.
And so you're feeling the transverse process and it's posterior with all the movements. Is there anything else, like anything in the history that would lead you to suspect that, or any other signs or symptoms that you'd be looking for?
No.
Okay.
No. Again, it's an instability that jams up. It's an instability I don't understand. It's a jam I don't understand, actually. The fact that I don't understand, I can't even give you a decent model on how it stays there. I really don't know. And I don't like the idea of just muscle holding it over. That doesn't make a lot of sense to me neither. So it bothers me from the perspective that I can't come up with a decent model. But what we do have seems to work okay. So no, I don't think there is anything characteristic in the history or in the symptoms or in the findings. Well, there's characteristic things in the findings, but there's nothing that would suggest that doing certain activities are going to cause it, or the type of pain they're getting is going to identify it. It's a biomechanical dysfunction with the differences we talked about. For those of you who just come in, we're talking about the transverse subluxation. And the question was, is there anything in the history or that would lead you to go there as far as what caused it and that's it, but no. So really it's exactly that. Position testing is helpful, very helpful here. It identifies it almost immediately, but your definitive test is try to do the glide. So when the glide doesn't move, you've got it, and that's it. I think it's a less extreme version of the Mackenzie shift. You know, these ones that are way over there and they're so painful. Well, Mackenzie modeled them as disc herniations, which they're not, but they're misdiagnosed as disc herniations because of the amount of pain they're generating. But it's all in the back. I think this is just a more minor version of that. It may not even be painful. This may, like any other subluxation, just jam up and then create problems everywhere else or anywhere else. Yeah. Okay.
Yeah.
All right. Amal and Saraf, have you got any questions for me? Anything you want to talk about? Sorry, you cut out a bit there, Amal.
I'm okay, Jim.
Okay. Amal?
Yeah, I'm okay. I'm okay. I'm just trying to go backward on the videos before the course. So
okay. All right.
Got no question.
Understand this. Don't feel reluctant to ask me because I actually like this. It means that I don't have to think of things. All right. Does me a favor if you've got a question or a comment. Okay, so what I thought I'd do is I just made a video for the US. So I thought I'd go through it with you because it might be interesting. So let's have a look. Okay, so what's happened here? What have we got here? Okay. What's interesting? Why is ChromaCam not working? I'll give it a second. Anyway, what I thought we'd talk about is approaching post-traumatic necks and a reasonable way of doing this that probably will cut out a lot of problems. If I can get the slides to show up. I don't know why I'm not. Okay. All right, let me do it this way then, see if I can find it here. Okay. Okay. Is that large enough for you to read okay? Yeah. Okay, so we're going to the main indicators you've got serious pathology is headache, dizziness, torticollis, and an immediate severe central pain. Now, obviously, headache, dizziness, and torticollis can be from a lot of things that aren't major problems. But this is post-trauma. I think, though, post-trauma, when the patient's most severe pain comes on within an hour or two of the trauma, you've got real problems. In fact, with emergency medical technicians, this is one of the things they look for when they look like post-trauma, is their patients complaining of central pain, and then they'll just go down and very lightly palpate over the spinous processes. And if that's tender, the immediate assumption is there's a fracture, a central fracture. So they won't do anything else. They'll put a collar on them, basically maybe give them some for pain, but not necessarily if they're thinking this might need surgery, and then they'll load them into the ambulance. So that's a fairly reliable sign that there's a major problem here. Even without trauma, central pain is suggesting something very unusual, and this could be pathological fracture, it could be tumors in the bone, and so on, but it would suggest something, a central tissue is giving you trouble. Not many there that's benign. You're looking at spinal dura, bone, and central ligaments. Now, without trauma, a lot of this stuff just isn't there. So you're not going to tear a ligament, you're not going to fracture a bone without some form of trauma. So when this is a more insidious type pain, you're probably looking at something worse than a fracture, actually. So these are all fairly major problems. So what we're looking at as far as conditions, high cervical fractures and dislocations. So C1, C2, and maybe C3, but these things, it's the high ones that create problems, but particularly C1, C2. ARFs, atlantoaxial rotatory fixations, are proper surgical subluxation. So there's actually a partial dislocation. So if you're looking at the dens and the arch of atlas, it actually does that. It slips forwards on one side and it does that. So that can be severe or it can be mild. But either way, it's not something you want to mess with. Intracranial bleeds, obviously, is a concern. And we're looking for progressive dull diffuse headaches here. VBI, headache and dizziness, and radiotranslucent serious damage. Now, there's some fairly major problems that are not going to change on x-rays. In fact, even high cervical fractures may not show on x-ray, especially dense fractures. If it's undisplaced, it takes time for the bone to be resorbed so it can be seen on x-ray. So radiotranslucent injuries that are not shown on x-ray, this can be things like rim lesions where you actually tear the vertebral body, the end plate, or through the disc. You actually rip this thing. Not going to show on an x-ray. Jump facets, which is quite a thing. I don't know if you've seen these. These are dislocations of the facet, and it can be unilateral or bilateral. What happens is usually front end collisions, so these are flexion injuries, and you come up and over. So the backs of the two facets are actually on top of each other. Now that can happen bilaterally, and of course, what you can do is reduce the size of the spinal canal. It's interesting. I think the number is only about 25% of these bilateral ones actually compress the cord, but they don't show on x-ray. The posterior columns do not show very easily on plain x-rays, so they don't show up. I might have told you this. I had a friend of mine who treated a patient for 3 months, very acute post-MVA neck, extremely acute. They did everything reasonable. I mean, it's a good therapist as well. They stayed away from manual stuff. They was basically, they even give them a month off of treatment to see what would happen. I was in a collar, I'm not in a collar, made no bloody difference. And finally, somebody did a CT on them, and that's exactly what they had, bilaterally, jump forceps. So that's basically open surgery, open reduction, then fusion. So none of this stuff doesn't show. Ligament tears don't show, and so on. So if you've got a patient with a very acute MVA neck, post-MVA neck, you don't know how seriously damaged that neck is. Even if they have had an X-ray, you still don't know how badly damaged they are. Fractured dens walk around. If this isn't displacing and hitting the cord, they're mobile, they walk. A lot of this stuff just works. Now, on top of that, you also get fractures that don't show up very well apart from the dens. Intra-articular fractures, subchondral fractures, sometimes pars fractures just don't show very well on X-rays and CT scanning. So this is the stuff that's not going to kill the patient necessarily, but it's the stuff that's not going to get better. So at some point or another, when you're not seeing improvement, this really needs to go back to the physician with a recommendation that maybe a CT scan is in order. Yeah. If we move down to this, come on, thank you. Okay, so across the top, you've got the signs. Down the side of it, you've got the condition. So high fracture dislocation, there probably will be a headache. I mean, you damage the upper neck and it generally gives you a headache. So this is going to give you a headache. That if this is a central fracture, though, the headache is going to be across the back of the head, not on one side. It may be worse on one side than the other, but it's going to be across the back of the head. And that's unusual. You also see that with VBI. It's a bilateral occipital headache with VBI. You may or may not get dizziness with this. And this is all about now, it's not about the artery, it's not about anything like that. It's about proprioception. So they're not moving very much. And a lot of this is about time. The longer they have this, the more likely they are to get dizzy. But don't forget, dizziness, type 2 dizziness, lightheadedness, wooziness, giddiness, nausea, can also come from the shock of the accident and the medication they're taking as well. So you have to consider all that. Torticollis, post-traumatic torticollis starting immediately where the neck is locked is never a good idea. So don't think all torticollises are benign. They're not. In children, 10 or 14 years of age, this can be an ARF, an atlantoaxial rotary fixation, where they've actually dislocated the AA joint, partially dislocated it. And this is part of, what the hell is that called? Upper respiratory, recurrent upper respiratory tract infections. I cannot remember what that's called. Anybody? It'll come. But this happens in children. So what the infection does is it weakens the dens. It basically softens the articular cartilage between the artery of atlas, the dens and the transverse ligament, and it makes this unstable. So these kids can dislocate their neck sleeping. A small tap in a car can dislocate this as well. So at that age, this type of torticollis can be really nasty. You also see it though on boys, adolescent boys, where they'll get better in about 7 or 10 days. And you can speed it up with treatment, but you have to be really careful. The trick is to ask about whether they're getting upper respiratory infections or not. That's going to drive me crazy now. And immediate severe central pain, we talked about that. Basically, post-trauma, you're looking at a disruption of healthy tissues. If this is a pathological fracture with the trauma just as a trigger, then the intensity of the pain won't be as high as it would be for healthy bone, but it's still going to be a sudden onset. It's still going to be related to more minor traumas often. Okay. So intracranial bleeds, you're looking at progressive headaches. Again, with or without dizziness, and a lot of this is about which part of the brain's affected. Now, usually in itself doesn't bother it. So what you may have going on there is a brainstem concussion or a cerebral concussion giving you the dizziness as well. Okay. VBI, headache and dizziness. and we're looking at being able to basically separate them out. So we're looking at coupling them and decoupling them from the neck pain, which is where we start to worry. Right? Or if they get neurological symptoms, or you're seeing neurological signs. Traumatic arthritis, they may or may not get a headache, depends on where this is, but they're not really going to get the other stuff. Over time, they may get dizziness as proprioception kicks in as well. And severe damage, depends on what the damage is as to what symptoms you're going to get. Okay. Yeah. So looking at progression, that's not quite as easy to see, is it? Let me do this. Come on, come away from there. I'm going to stop sharing for a minute. Okay. Oh, bugger, I can't do that. Sod. I've tried to do that before and I can't do it. All right, that better? So if we're coming in, all right, we've got a post-traumatic neck. Motor vehicle accidents are particularly nasty. So you're really looking at making a null hypothesis here and then trying to disprove it is really what you're coming down to. So H1, you can take your pick of any of these three, but I would do the ones that are more immediately problematic. So fractures, high cervical fractures, dislocation. So basically you're looking at the essential illness script for this. Sudden onset of severest pain, central pain and tenderness. Just remember though, if you are going to palpate for tenderness, this is done very gently. What you don't want them doing is jumping and then displacing the fracture. So don't do that unless you really feel the urge to do it, the need to do it. Central pain, an immediate onset of central pain is generally enough. I won't worry about palpating. Deformity, torticollis or a step in the neck. And I haven't mentioned it there, and it's a talk deformity. And the C-spine rules, the Canadian C-spine rules being violated. And that should have meant an X-ray. So if they haven't had one, then they need one. Now, this isn't an emergency necessarily. So under that circumstance, provided you're not getting any other stuff, the doctor should be contacted and told this patient should have had an X-ray according to this, and they didn't. So it depends on who saw them. If the GP saw them, he's at fault. If the emergency room saw them, they're at fault. They usually don't make this sort of mistake. Anyway, if you accept it, it goes either to the emergency room or it goes back to the MD asking for an X-ray. If that has been refuted, that hypothesis, your next one could be intracranial bleed. So now we're looking at headache, which is progressive, deep dull diffuse, and gravity dependent. Is that okay? The idea of gravity dependence? All right. So again, if you're going to accept that, that goes to the emergency room. You have no idea where that is. This can take 3 weeks or so before the patient actually collapses from it. But that may occur in a day or a week. You have no idea. Get that out of your clinic as soon as you can. You want an ambulance, really. Or you drive them to the ER, but they don't want to be driving. Somebody needs to drive them to the ER, either the ambulance or somebody else. If you refute that, then VBI. So now you're looking at dizziness and posterior headaches, with the headaches and dizziness being coupled and decoupled from the neck. Now, that doesn't always work out that nice. So you may get, they're coupled together and they're uncoupled from the neck sometimes, and they're coupled with it other times. Go with when it's uncoupled. So basically, if these are referred from the neck, then what you should be seeing is they should never come on without the neck pain. So even if it's doing it sometimes and not doing it others, then don't do it. If it's coupled all the time with the neck pain, then it may not be VBI, but it still might. Because you don't know what neck pain is associated with the VBI, the injured artery, and what neck pain is from the musculoskeletal system. So you want to be really careful with that one. And if you're not happy with it, don't mess with it too much. If they've got neurological symptoms, get it the hell out of there. Or if they report neurological symptoms, when I get dizzy, I also get blurred vision. I also get pins and needles. That should go to the emergency room. So neurological symptoms coupled with either dizziness or with a headache, not necessarily both of them. It probably isn't VBI, but you've got something else going on there. All right. And then if you find signs, neurological signs, central neurological signs, mostly it's going to be cranial nerve, then get the hell out of there. All right. Now, if that's accepted, it goes to the emergency room. If you refute it, you continue with the exam, but remember what we said. This may be fairly severe damage that isn't showing up on x-rays, and it may not be life-threatening, but the prognosis for this sucks, basically. So give it a fair amount of time, give it a month or so. But if this isn't getting better in a month at all, and you're doing everything right, and their patient's doing everything right, get it out of there and ask for some either MRIs or CT scans. All right. Do you have any questions on that?
Nope, fairly straight.
The thing is, I think you're better off under these circumstances going in as a worst case scenario and then disproving it. Not going with it's a biomechanical dysfunction and then proving that, because the fact they got a biomechanical dysfunction does not mean they don't have more serious damage as well. Yeah. So go the serious route, disprove it, and then move on with your life. Okay. Most of your MVAs, though, you're not going to be doing much to them in the early stages anyway. They're too acute, they're too inflamed, they're too sore. My suggestion is you put a colour on them. It really is, makes all the difference in the world. And everybody who says it's bad for them is talking bullshit. And there is studies proving that, regardless of what the Quebec Task Force idiots said. All right. Have I talked to you about collars and necks? Well, let's do that. There was a study done in Australia. It's done by a PhD student named Guru Murthy, and his supervisor was Lance Toomey. Now, I don't know if you know Lance Toomey or not. This guy is, if I was going to try and model myself after anybody, it would be after him. He's a complete gentleman. He's extremely competent. He's very bright. And yeah, what they did was they took 220 odd post-MVA patients, all within 48 hours of the accident, excluded anybody who had a fracture, and then divided them up into 3 treatment groups. One was considered the control group, which was left with the physician to do whatever the hell they normally did with them, except refer them to therapy. So generally that consists of a soft collar, exercises, drugs, and all the rest of the stuff. There was an early activation group where they got them active very quickly. And then there was the collar group. They went into a hard collar, a Philadelphia collar. They wore it 24 hours a day. They slept in it, worked in it, did everything in it. The only time they took it off was to wash their neck and shave. That was it. And then when they were in the shower, they had 2 collars. Another collar went on after they'd done their neck, whatever it is they're doing there. And they were without the collar for maybe 5 minutes a day, something like that. Otherwise, they're in it all the time. Then they checked them at 0 weeks, as on entry, 4 weeks, 8 weeks, 12, 26, and 52 weeks, something like that. And they checked them for pain levels, strength, mobility, and return to function. The collar group statistically was the worst of the 3 groups on entry. It was the only group that reached 50% of them achieving full function at 26 weeks. No other group did that. And that collar group did better than every other group at every measure after 4 weeks. So it's basically telling you this: you need to let this rest. And I don't see why this is a mystery. This is exactly what you would do with a knee, a hot, swollen knee. You won't have them running on the bloody thing. You let it rest. This is no different. They need to rest. After on the collar group, where they did 4 weeks, they took them out of the collar and put them into the activation group. So it's telling you one thing: if you're going to do one thing to MVA patients, put them in a hard collar for a month. Yeah. So I've got no problem saying this, and they don't get dependent on it if you do it right. If you tell them that you're coming out of this in a month, right? Don't get used to it. Going to come off in a month. And in all honesty, the chance of you actually getting someone outside of a research group to wear a Philadelphia collar 24 hours a day is pretty much zero. So I use a stiff, soft collar, and I tell them to wear it at night if they're waking up with it, pain in the morning. If not, don't worry about it at night. And even that seems to help. It's the only thing that seems to make sense to me about this. Now, MVAs are not like other neck injuries. There's an extra force in that you don't see with any other type of whiplash. Sports injuries, when they get in the back and their head goes back, that's whiplash. But you don't have one force, and the force is compression. And what they found is that when you hit from the back, you're getting an anterior shear on you, so you're going forward. It's not your head's coming back, your head's staying still and your body's moving underneath it. But there's also an upward force underneath your ass. And the more vertical the seat back is, the higher that vertical force is. So the head stays still again. This force comes up from the bottom and it compresses everything upwards against the head. And then you have this backward movement, or the anterior movement, which is backward to the head. But there's no translation. That compression stops the normal translation of extension. So what you get is extra gapping at the front. So this is where a lot of these rim lesions come from. So I can't think of any other activity that's going to do that to you, except perhaps being hit at hockey, ice hockey, and going straight down on your ass as you're being hit. Otherwise, I can't see it. I can't think of anything else that does that. So these studies that say that motor vehicle accidents are all fake because there is minimal perturbation. So if they apply the same forces, which may only be 5 or 10 miles an hour, they apply the same forces artificially by pushing you forward at that speed, you don't get these injuries. But probably the difference is that compression load that you don't get just by pushing you forward. Anybody who thinks these are not genuine, I love getting them as patients. I've had doctors who won't accept whiplash until they get one. And they say, oh, my neck, help me. You know, screw you. There's nothing wrong with you. You said so. I believe you. So I think this tends to be one of the more difficult patients to treat. Would you agree? Or not? These can be a real bitch to treat. And I think it's because the mechanism is completely different from anything else. Yeah. Okay. So have you got any questions about that? Motor vehicle accidents in general?
So Jim, when you put collars on, you recommend the 4 weeks?
Yeah.
Typically? Yeah.
Well, yeah. I mean, often you'll get patients like your trim say, can I get out of this? It feels really good. Yeah, fine. Yeah. You got to remember that that group of 220, a third of the 270 odd people that had collars put on them have all got varying amounts of injury. So
right.
Not uniform. So some of these are going to be not good at 4 weeks, and some of them probably didn't need in the first place. So you've got this mishmash. So no, it's going to need it. But for me, if they say, can I get out? I'll say, yeah, sure.
Would you have specific criteria that you would be looking for to put before you put them in a collar?
I think, yeah, I'm looking for somebody who obviously has traumatic arthritis.
Okay.
So this is not somebody. I'm looking for somebody with an acute neck. So I'm looking for somebody who's got significantly limited range of motion. These are the ones you see. You don't see the ones that, like, I don't know how quickly you get referrals with MVAs, but my guess is it's probably a week or two in, isn't it? Yeah. I was in BC. I've actually taken glass out of people's hair from that. We got them that quick. But yeah, it's a doctor's here. They're fucking horrible. The sooner you see them, the better. So when you're seeing that, there's a lot of these people you won't see because they're going to be better in a week or two. But if they're still having significant problems in a week or 2 weeks, these are probably the people who need to go into a collar. So my guess is that most of your patients are going to have significant limitation of movements, significant functional loss, and you're looking at traumatic arthritis. Well, it takes a couple of weeks to get that down if you're doing everything right. If during that 2 weeks, they've been doing all the wrong things, they've carried on working, doing all this crap, then that arthritis hasn't gone down at all. It's probably not any better, and it may well be worse. They need it rested. And it's interesting because the numbers say the same thing. The average MVA who sees a doctor will take 3 weeks off work. They either take, the best thing to do is take it all at the front end. Maybe take 2 weeks off and then save a week just in case you go relapse, but take 2 weeks off at the front end, instead of which they'll take a day here, then they have to, a week later, they have to take another day off because their neck's so bad. So they'll take the 3 weeks off, but they'll take it in dribs and drabs. It's not doing any good. It's just sort of letting them catch up so they can go and injure it again. So they need resting, but it's, of course they bloody do. They've got traumatic arthritis in the neck. Of course they need mended. What should happen is you should be able to get the inflammation down fairly quickly. If you do everything right, they rest it, you get the inflammation down quickly, you're then stuck with the biomechanical dysfunctions that this has triggered, and those you can treat with manual therapy. But they come back again much more often. And I think it's because there is also neurophysiological and neurological damage that isn't shown up. So I think they damage brainstem in a minor way, so the cranial, some of these cranial nerves, particularly the vestibular stuff, they can damage this and be asymptomatic, but it screws up the reflexes. And there's a very definite pattern you see when this is happening. They lose elevation of the arm and they lose rotation to that side. And you can actually, when you check the eyes, you get these glitches in the eye movements, and you can iron them out. You do some exercise, this becomes full range, and the neck range improves dramatically. It's doing that has cut the number of manipulations I do down in the post-MVA neck by 1/3 or 2/3 even. And what I get rid of are the facet joint problems. I'm left with the unconvertible joints. So it may only take one manipulation. All of the craniovertebral joints I used to manipulate, I don't anymore. I can't remember the last time I manipulated a craniovertebral joint. So I think a lot of this is neurological, neurophysiological, and that's a balancing act between the vestibular system, the eyes. Yeah, probably, yeah. They've just buggered up the neurophysiological system, and you have to work on that. So just manipulating the neck, you're not doing that much for it. So you have to work on that as well. As for putting a collar on them, yeah, I mean, honestly, if they're still in significant pain, bad enough to come and see you, they should probably be in one. Yeah. Anything else? Okay, well, I'm running out of things to talk to you about. Have you got anything? Hang on a minute. Let's see if I've done anything interesting recently. Yeah, I don't think I'll talk to you about Bayes' theorem. After that. No, it's a bit long. It's very long. Harsh, Tulu, did you look up Bayes' theorem?
Hi, Jim. Did I look at what?
Did you look up Bayes' theory, Bayes' theorem? Yeah.
No, not yet.
This really drives me crazy. They talk about evidence-based practice, and what do they give you statistics? Spin and snout, don't they? It sucks. But it's worth looking at. It really is. Just go on there. So they're 15-minute videos. Pick one and look at it. Bayes theorem or Bayes factor actually is a good one. It simplifies the whole thing a bit, but it's well worth looking at, because you can't do a test, know its sensitivity, specificity, and say, okay, this is the chance of them having this problem is really high, simply because the test is really good. If they haven't got the signs and symptoms of that test, and there's no likelihood of them having that condition, that doesn't matter how good the test is, it's still a false test. Whether it's, well, if it's coming up positive, then it's a false positive if they haven't got that disease. If they've got no signs and symptoms for it and no likelihood of having it, then how good the test is doesn't come into it at all. You are better off with a bad test and a likely patient than that. So have a look at it, because it's something you should know, and it's what really, I do not understand how an academic institution like a university can send you out with spin and snout. They suck. They suck at everything they do. They suck at clinical sciences and they suck at the academic stuff as well. It's appalling how bad they are. It baffles me, absolutely baffles me. They're getting paid for them. They're getting paid to do a crap job. I said in the class, it's a good job you're only paying, what, $300 a year for your tuition? Anything else and you are seriously overpaying. What it does is it gives you a license to go on continuing education courses. That's about it. Yeah. All right, have you got anything else you want to talk about? Otherwise, I'm in a mood to get myself drunk. So I've got no problems drinking on my own. I'm still not allowed in bars yet, so I can't go to a bar.
Jim.
Yeah.
Can you just talk about the treatment options available for hip subluxation?
For what subluxation?
Hip subluxation. I know we discussed it in class on Sunday.
Yeah.
But then I was just wondering, like, if a patient comes in with problems in the hip,
yeah,
and you try to manipulate it, and
yeah,
then with the and also symptoms in the back as well.
Yeah.
Would fixing the hip alone,
No.
would that be enough to fix the problems in the back?
No, that's a general question. It's a good one, actually. This is what people do. I found the cause of the problem. If I treat the cause, the problem will go away, and that's not true. The pathology is present. What caused it is in the past. Now, if that past is trauma, there's bugger all you can do about that. If it's not trauma, and it's like we're talking about with the hip, not extending and stressing out the lumbar spine, you can deal with the hip. But that doesn't mean to say the back's going to get better. So you treat both. The problem with this is keeping it better. But this is the problem you always have with this stuff. Manipulating is easy. And you can do rehab with them. You can do all this stuff, whatever rehab you prefer. You can do all that rehab, but if the patient doesn't do it, it's all a bit pointless and they won't do it. Anyway, that's what keeps your mortgage paid. The same people coming back and seeing you periodically. Honestly, I don't follow up. If I've got to have my back manipulated. I'm waiting to come to Edmonton. I'll get Bob's to look at it. But it needs to be manipulated. But I tell you what, I'm never going to exercise it again. Yeah, I'm not going to go through all of these exercises. I'll get it remanipulated. What I want to know is, can I get it manipulated safely and it's not going to bother me? As soon as Bob can do that, then I'll get it done by somebody in Mexico. But I'm just right now, I just want to know that I can get it done without it crippling me. I trust Bob Sydenham. But yeah, I mean, these patients are not going to do it. I'll come back. And if you explain this properly to them, you're going to be doing these exercises for at least 3 months. You're going to be doing them every hour of your waking day. Otherwise, what? Otherwise, it's going to come back. When's it going to come back? I don't know. 2 weeks, 6 months. I don't know. Well, okay, when it comes back, I'll come back and see you. So if it's 6 months down the road, you manipulate it once now, and it's better for another 6 months. What would you choose? 3 months of exercise, he'll come and see you every 6 months. Yeah. Only an insane person or an athlete, well, that's the same thing really, or an athlete would choose the other option. It's because they're conditioned to exercise. Well, good luck to them. Exercise burns up heartbeats, and you've only got 1 billion of these suckers, and it also destroys neurons. Don't do it. Very bad for you. Oh no, treat both ends, Tolu.
All right, thanks.
Okay. Anything else? All right, well, I'm done. I'm going to go and get drunk.
Enjoy your night.
I will.
Well, see you tomorrow.
All right,
Yeah.
thanks.
All right,
Thanks,
guys.
Jim.
I'll see you next week. Take care, everybody.
Bye-bye.
And I'll see you and Tolu and whoever else is on this course Friday, tomorrow. Yeah.
Tomorrow.
All right. See you guys.
Bye.
Yeah, bye.
Bye.
Bye.